Thank you. Can people hear me okay? Great. And thank you for all the visitors. I hope it's worth the visit. And I think some of you guys have met before. Maybe a little bit of a disclosure caveat. So we are here mostly with kind of expertise in psychiatry, mental health, and we hope increasingly with expertise in evaluation and safety. And we recognize that many of you in the room are much more expert at some of the things that we have aspirations towards. And so we've been actually really grateful for some collaborations we've had here, and very open to your feedback around a number of things, especially things that are not my main expertise. We want to acknowledge a number of people who've helped us along the way. And we hope you'll let us skip over this slide so we can get to the content, because it's this tension around acknowledgements versus wanting to get to something that is a bit meatier. And we don't really have any disclosures that we think are the type of disclosures that are important around being funded by vaguely nefarious kinds of organizations. But I will say, particularly wearing my psychiatrist hat, that amongst the things that we have tried to grapple with as we've been trying to think about how to improve safety for our patients and for the staff who care for them on the front lines is recognizing how tricky notions of sort of stigma and balancing kind of one individual's safety versus another individual's safety is, and it's a real tension. And sometimes even language is a tension around occupational health and safety language. This group will be very familiar with that. Using words like violence is a very challenging word for me to use as a mental health professional in terms of thinking about the kind of experience of colleagues who've experienced harm in a really serious kind of disabling way, and also recognizing how sometimes the word violence can seem to mean intention, when in my experience it doesn't really mean that at all in many of the experiences of our patients. So I won't make a bigger disclosure than that, but I want to acknowledge if I trip over words that people feel are the wrong words or they're offensive in some way, I'm happy for feedback so that we can have these kinds of conversations together. We're going to talk about this behavioral universal precautions research project, which we hope is kind of a way to move forward around trying to kind of keep frontline staff and clinicians and people who work in healthcare settings safe, while also trying to take in notions of stigma for our patients as well. So we're going to tell you a little bit about how we got here, not to kind of be too grand about how we got here, but to give you a sense of why this particular project emerged from an evaluation and a research perspective, and then tell you about the actual research project itself. So with appreciation, some people in the room are also clinically oriented and some people are very kind of safety and workplace oriented. We're going to try to meld those two together. Apologies if it's too much or too little of that for some of you. We'll tell you a little bit about the challenges of addressing patient-aggressive behavior in an acute healthcare setting, a little bit about some of the recommended approaches to that, and then our randomized controlled trial evaluating a new intervention that we developed. Any questions so far? I'll assume people interrupt me. So just to give people a little bit of context for people who are of less of a clinical context, from a mental health perspective, at any given time in most acute care settings, and it's true in long-term care and in rehab settings as well, one way to think about what's happening in a hospital, which is my main kind of home, is that although we may think of a kind of psychiatry unit or an inpatient psychiatry unit as a place where there are patients who have mental health problems, and we should, across the whole kind of hospital, there are many patients with mental health burden. So you'll have people in the ICU who might be confused and delirious related to an infection, people who are admitted with substance use disorders and infectious consequences of that, who may be dysregulated and be on a cardiology floor, people who have dementia, increasingly sadly are admitted to hospital because their level of behavioral disturbance has exceeded what their retirement home, what their families, and what their long-term care facilities can support. So in many ways, the hospital is kind of a final spot for lots of different entry points for people who may have a combination of medical, physical, and mental health burden. And they kind of come into the hospital and are cared for all over the place. ICU, mums and babies. We have, women who may have postpartum depression, postpartum psychosis. So they're kind of, it's a heterogeneous place with a mixture of both mental health burden and physical functional burden. And it's important to keep in mind because most acute care hospitals would have more patients with mental health burden and possibly kind of dysregulated or risky behaviors in greater proportion than the actual number of patients on their psychiatry units. So for example, at Mount Sinai, we have a 15-bed inpatient psychiatry unit, so that's 15 patients. And at any given time, the psychiatry kind of roving consulting team is involved with about 50 to 70 other patients in the hospital because of their mental health burden. And so they would be all over the institution, and really identified as cardiology patients, but who might also have behavioral symptoms. And so some of these pictures are meant to remind me to tell you they may come from dementia, these kinds of behavioral symptoms. They may come from substance use disorders and withdrawal, may come from somebody who might be manic, may come from somebody who might have had an overdose in the context of suicide or psychosis. And so as you can probably imagine, without being a healthcare professional, these folks kind of come in all shapes and sizes and have a lot of needs, and are being cared for largely by nurses and physicians who are not trained in mental health, right? So they're also cared for largely in physical settings that are not purpose-built for people who have mental health problems. So they're not physically safer, they may not have more secure settings, there may be vulnerability to sharps or ropes or things that may be projectiles for nurses who are providing care. So again, not wanting to be stigmatizing at all, mostly to kind of highlight that it's a bit antiquated in many ways how we have our hospital set up, right? We have cardiology floors and mums and babies floors and psychiatry floors, and most people come with more than one problem. And so I often think about kind of the mental health burden for many of our patients. It's almost like the backpack that you came with. You came with your heart attack, but you might also have your dementia in your backpack, or you might have a substance use disorder in your purse. You've got all of the things that kind of have brought you to this moment in time. And so one of the things that kind of emerged that guided just briefly our sort of safe patient, safe staff work is, Carla and I, part of the clinical work that we've done for almost 10 years now together, is providing psychiatric support to patients who are everywhere but on psychiatry. So providing that kind of care on request from a number of colleagues. And amongst the things that became very apparent, and is very apparent in the literature, as people will know in terms of the safety literature, is the experience of nurses in particular, although other healthcare providers are often involved in care as well, is one often of feeling ill-equipped, helpless in terms of providing care to patients who also have mental health burden. Imagine you're a cardiology nurse, you're super skilled at delivering cardiac care, but you may not be supported, kind of from an infrastructure, training, et cetera, to identify mental health needs and behavioral symptoms. And, we were hearing many, many things, colleagues saying we need to keep ourselves and our patients safe, nurses saying I got kicked and scratched for no reason, I'm just trying to do my job, people kind of asking, do you know how many times I've gone in to give care and been hit from out of nowhere? Someone saying, I sure hope the nurses wouldn't stop caring for my mom just because she tried to hit one time when she was in pain. And that's what families are saying. Families are struggling also around, how do I make sure that my mom or my sister gets help, even though the nurses are telling me it's really hard to care for her and they're almost afraid to go in, for fear of their own safety. So one of the things we've been working on for the last several years and have done some other research projects about has been, this idea, which is not unique to us, we've borrowed it from lots of other excellent programs in healthcare, is the need to be proactive around the vulnerability in healthcare. So just to give you a sense of it, if somebody wanted psychiatric care for one of these patients on mums and babies or medical or surgical floors, they'd have to wait to identify it. The physician would have to call for a consultation. Often days would pass because that physician or nurse might be a cardiac nurse or a cardiac physician focused on the heart attack, not necessarily noticing that while they're not there, there's lots of behavioral symptoms of either dementia, delirium, psychosis, et cetera. And so we've developed a series of interventions, which we can talk about at any time, to be more proactive, to identify patients as early as possible. For example, we have data mining software that goes through all of the clinical documentation every 12 hours, looking for any words that might suggest that a patient is combative, agitated, et cetera. We're the only hospital that does that. And so that's amongst the interventions that we've done over the last little while. And we have standardized care plans to try to address patients who have what we describe as high risk and high needs, and some education involved as well, and some collaboration with occupational health and safety. And so that's our Safe Patient, Safe Staff program. And we named it that because amongst the things that we were noticing amongst our nursing colleagues in particular, although it's not unique to nursing, is I think our nurses were feeling very much burdened by the expectation that they would go in and deliver care no matter what. They experience that from families, from physicians, and our nurses, like most places, are kind of amazing, and they will go into they'll run into fire the way that firefighters will run into fire, even though the actual physical risks are there. And we had learned from our nurses that they'd had some other interventions before we began this program that felt like they were basically about blaming nurses for not being able to somehow deliver care safely. And we wanted to highlight in all of our interventions that there's no such thing as a safe patients program. There's only a program that also makes sure that the people delivering care are also safe. So that is part of the rationale for that. So as we've been delivering, I'm going to give this to you a second, as we were delivering more proactive care, we discovered there was an important gap that was affecting both clinicians and non-clinicians, which Carla will tell you about, which led to our research project.
All right, so yeah, so as we started to do more work and tried to be more proactive and have the care plans in place, we came across a particular patient case in which we realized that the work that we were doing with the nurses was not enough. So this particular patient, he was elderly, but he looked quite young and he had dementia, and he began to believe that his hospital room was his own room. So anytime anybody entered his room, he yelled very loudly, and he did have some physical aggression towards people, but it was mainly the yelling. And this came out where we were seeing the service assistants who are cleaning the rooms, the staff who are delivering the meal trays, they were running out of the room terrified. And so we began to realize that it wasn't enough just to have all the nursing staff aware of this patient's needs. We needed to think about how to communicate it to everybody, what the risk was and what the care plan would be. And so that began us thinking of how would we do this to communicate these risks to everybody. And so we then thought of what infection prevention and control did and thought about how can we do something more similar to that, in the sense that all patients from the hospital perspective have routine practices where we think about cleaning our hands, wearing gloves, wearing more protective equipment in certain situations, but that also that people are screened for antibiotic resistant organisms. And if they're positive for those, they're applied certain precautions. So having signage at their door, having the particular equipment that you're supposed to use, and telling the patient about that. And we began to think, how can we do something similar, but where the risk is not about infection, the risk is about aggressive behavior or violence. So just quickly, we'll get to what we did. Just quickly, I won't spend a lot of time on this for this audience, but we know that workplace violence is very common in the healthcare sector, and that for most of that aggressive behavior of violence, it's the patients who are the source of the violent behavior. During the time when we were developing this, we were also supported by the changes to the occupational health laws, which said that employers need to protect all workers from the risk of workplace violence, in the sense that they needed to communicate this risk when the risk was known. So that gave us a bit of an a way to allow us to communicate what might be considered personal information. We know that there's considerable negative impact on staff, both in terms of the physical injuries, but also the psychological trauma. And we also recognize that there was a negative impact on patients. So when somebody is having these types of behaviors, it becomes very hard to deliver the needed clinical care. And then it also leads to people needing restraints, physical and chemical, and it can be a traumatic experience for the patient. In our organization, there was a lot of people that were involved in trying to address this issue. So we had occupational health and safety, security, risk management. We have a department of diversity and human rights that was also involved, the Joint Health and Safety Committee, and we ourselves had developed a behavioral rapid response team. So a number of things were already in place, but we still wanted to figure out how can we take this a little bit further. Interestingly, this was in the same sort of timeline as when we had developed this project. So this happened a little bit after we trialed it, where they developed the ministry developed like a report on what should be happening, and the tools that were developed by the Public Service Health and Safety Association were also recommended. And we had seen these tools when they were in draft form, and we'd kind of come up with a very similar intervention, so where we're assessing clients for individual risk and then looking at how to communicate that risk through flagging. And so when we were looking at the literature, we found that there wasn't actually a lot of great intervention studies that told us what to do. And that the things that had been found effective were worker education and training, and then flagging of high-risk patients. So from that, we knew that we wanted to include that in our program. When we looked at training, we found that the different training interventions were able to make an effect on staff confidence, but not necessarily attitudes or knowledge. And most of these weren't actually looking at whether it changed the rate of violent behavior afterwards. And we did find that the post-training follow-up seemed to be really important in reinforcing what was taught. So training alone wasn't going to make the difference. And then as well, we looked at what is the literature supporting the need for flagging. And so in BC, they had implemented a flagging system and found that while it didn't change the overall rate post-implementation in terms of how many violent incidents there were, they did find that they were correctly predicting who was violent later on in their admission. And then there was also a study in the Veterans Health Association in the States. This was quite a bit older, but they had implemented flags and then had care plans for those patients and found that there was considerably lower rates of violent incidents in the year following. We also tried to reach out to other organizations to find out what they were doing about this issue and how are they implementing the flagging system. And we just found that there was considerable variation. So there's different screening tools that are used to try and identify which patients are at highest risk. There's variation in who fills out the screening tool, at what point it occurs, if it's reassessed at any point. There was also considerable variation in what people were using as visual alerts, whether it was wristbands, signage, if it could happen on their electronic health record, if they had a unit whiteboard displaying all the patient names. Some of the organizations, rather than having something that was applied by a general staff, there was only the manager that could apply a flag, and it was a permanent flag that displayed across visits. And then also what type of visit? Was it just the outpatient, or just the inpatient visit? Was it outpatient? Did it last across visits? What we found when we additionally are trying to implement is that it's also based on what is possible both in your electronic health record, whether you're using a paper system. So there's a lot of logistical issues that influence this. We also realized, as we've alluded to, that we're a lot of concerns about stigma, and this came out earlier this year where there was complaints put forward about the way that this was implemented in London here in Ontario. And so when we look at the particulars of how they did their system, can kind of see why people would get upset, but we also wanted to avoid this type of reaction. And through all this, there was a lot of things that we were balancing. So wanting to promote safety for everybody, but also wanting to balance that with privacy and confidentiality. How can we be preventive, proactive, protect workers, but avoid being stigmatizing or labeling people? And as well, valuing our values changed recently for our organization, and then how is this going to be reflective of that? And it's recognized in any sort of flagging system that we do want to avoid stigmatizing at-risk people, but also just the fact of labeling people with these visual alerts, it does feel like we're stigmatizing them. So how do we balance those two things? And we're not saying we have an answer, but just when we walk through what we're doing, some of our choices are trying to reflect this concern. So what did we actually do in our research study? So going back to the way that we were trying to mirror infection control, when somebody arrives as an inpatient, the way that our program works is that the nurse completes an aggressive behavior alert screening tool. And based on that tool, if they're high risk, we're using visual alerts. This tiny diagram is meant to indicate that. So we have signage on the door to their room, above their bed, and then the tiny little pink thing is a sticker which goes on their chart and on the nursing binder, the Cardex, and then the patient wears a pink armband.
Actually, so it might be worth highlighting, in case it's not clear. No, it's okay. I'll speak close to you. One of the things that we were particularly kind of interested in, which I hope also interests this group, is that this is one of those kind of areas where there's lots of so-called leading practices, many of which have never been evaluated, right? So what we were trying to kind of think through is not just how to do whatever the latest is that we can check off that we are kind of adherent, which I'm sure comes up a lot for this group as well, but how can we think about, does it actually work, not just as a process outcome, but as an actual outcome. And in particular, if you present this kind of intervention to colleagues, how adherent are they going to be to it so that we can actually get to something that actually leads to safety as opposed to a compliance checklist, which is, the compliance checklist, as we all know, is better than not complying, but if it doesn't get you where you want to get to, then it's a lot of energy and work that are in addition to what the work is that our nursing colleagues already do. Sorry.
Yes, that's okay. So in addition, if somebody is high risk, then the nursing staff develop a care plan, and this is looking at the particular person's, what are their triggers, what are the actual aggressive behaviors, and what strategies help. And then there's communication strategies both amongst the healthcare team as well as with the patient and the family about the use of this program. And so for our research design, we rolled this out with a set of 6 units, with half of them being the experimental units and half of them being the control units, and they were matched. So we had a pair of medical units and then 2 pairs of surgical units. And on the experimental units, they received training that was pertained to like how to manage workplace violence. And then they also received ongoing audit and feedback about the use of the program and support in sort of developing the care plans. And then on the control units, all the existing protocols remained in place. And just out of note, we also implemented on the psychiatric unit and the medical unit in the same time frame, just because these places wanted the program, but they weren't involved in the research because they don't have matches for them. And then we involved as many staff as we could. So training was provided to everybody that's in the unit-based category and the floating category. And as you'll see, we tried to get both those like clinicians, but also the people that are in the more like support staff roles. And then the people that we didn't actually provide the didactic training to, they were given written information about the program. So, and these were people that it's very difficult to try and train, or that, which would be the physician group, or people that there's just too many of them. Sorry, physicians.
Someone could figure out a study to figure out how to make us show up for anything.
Yeah.
That would probably be,
yeah. And the training was short. It was only about 30 minutes long, and it was delivered by myself and the other nurse, Mavis. So we delivered all that training. So what were the results? So just in terms of what we were doing to measure the outcomes, we were looking at both like, were we successful in having people actually do the intervention? So the first set was like looking, did people actually adopt the things that we wanted them to do? And then we also had staff doing, so that was the first one, and we were doing both spot checks on the unit to look at they were doing the different parts of the process, and then a knowledge questionnaire for staff to see if they learned anything from our training. In terms of the staff, then we were then watching them to see if there was any changes in their attitudes, knowledge, confidence, and experience of aggression. And they did questionnaires both before the study began and then at 3 months and 6 months after it was implemented. And then the last part is that we did qualitative focus groups looking at what were the barriers and the facilitators to people using the program. And that we did just with the nursing staff from the intervention units. So when we look at how did it go in getting people to adopt the program, we had targeted trying to train at least 80% of staff, and we reached that for all of the unit-based staff. So that was mainly the nurses and the ward clerks. We didn't reach that for the floating staff, but that was largely driven by the very large support staff group. So they numbered hundreds of the 553, and the way that we were allowed to train them is that once a month they had a day where they had meetings that were staff meetings that were staggered, and we were allowed to train whoever showed up to those meetings. So it was sort of whoever was working on that day and came to the meeting. So for that reason, their rate, I think, was only about 40%, whereas for the more clinical type staff, their rates were all very high, more similar to the nursing rates. We also looked at whether people adhere to different parts of the protocol. So there was the need for the patient to be screened within 24 hours of arriving on the unit. And we had targeted having 80% of patients screened within 24 hours of arrival. With all of the ongoing audit and feedback, we saw rates that were in the 70s, so 74.7% overall for the 3 units, which we thought was okay, because when they do audits of things like how often do people do vital signs, it's a similar rate. So I think we all agree, and hand washing is less. So even though it's not great, when we look at other comparable things, it's totally acceptable, unfortunately. And then we also looked at whether people were using the visual alerts. So I described the visual alerts. We had 5 different visual alerts, and in our imagined way that this program is going to work, 80% of the time they were going to use all 5. And we saw nothing approaching that. When we looked at using all 5 alerts, there was like only happened about 8% of the time. Mavis and I are like pretty sure we put on all those alerts whenever that happened. It was only a couple people. Because not very many people are positive is the other thing to say. Only about 5% of the patients are positive. But when we looked at if people use at least 1 alert, then we were approaching sort of an acceptable rate of in the 70s%. And so going forward, we're thinking about how to modify the program. One of the things we think we'd modify is to have less alerts and make it very consistent that we just use a couple alerts. And we had no automated alerts just because of the limits of our electronic health record. The other thing that we looked at is whether staff's knowledge improved after our training. And as you'll see, there's like no significant difference in the knowledge before and after training. And the sad thing that we figured out, which I have to admit, is that we were really bad at writing a knowledge questionnaire. When we reflected on that, it was just not a good questionnaire. And so that is not our skill set, writing tests, yeah, for others. But the more interesting data is sort of looking at how did staff experience the program. And so what we were hoping to see is that the people that were on the experimental units are going to improve in terms of all of these outcomes over the course of the study, whereas the people on the control units were not going to change. And we thought that we divided them up into both people that were on the experimental units and then also the people that floated. And so I didn't actually specify the floating. The floating is people that might work on more than one unit. So the nurses are usually assigned to a particular unit, but other sorts of staff work on multiple units just due to the nature of their work. So those are the floating group. And so when we looked at how people did over time, for the knowledge, this was our investigator-developed questionnaire, which I've already admitted we are not good at doing, and so we didn't see any differences over time or between the groups. But for the other outcomes, we used published surveys, so the outcomes were a little better. So in terms of the attitudes, we used a questionnaire that had 8 items, and they all had to be analyzed individually. And when we looked at this, only one item out of the 8 showed any difference over time. And this item, when you read the question, is actually about confidence. And in that group, we saw that both the experimental and the floating group improved over time and the control didn't change. So this was sort of the outcome that we were looking for. However, even though it was under the attitudes, it was more about confidence. For the actual confidence outcome, we again used a published tool, and this one had 10 items, but you could sum it up to create an overall score about your confidence. And with this, we actually saw that all 3 groups increased in confidence over time. So the control group also improved. And again, this wasn't exactly what we were expecting, but when we looked at this and we broke it out by the 3 units that were in the control group, it was driven by just one unit, and it was the medical unit. And that unit, during the study time period, had a lot of patients with behavioral issues. So they weren't getting support from this aggressive behavior alert program, but they were getting support from our team on managing those patients to a level that they wouldn't usually get. And so we think that could possibly explain why their confidence was increasing. The last one that we looked at was experience. And so with this, we used some questions that just asked about people's experience of different types of aggression in their last set of shifts. And so it had 5 individual items. And this was sort of what we used instead of having a way of measuring the number of violent incidents that were happening, because we recognize that our incident reporting system is grossly unreported. Code whites happen way less than aggressive behavior. So we didn't have a good way of getting a sense of just how much aggressive behavior was happening on the units. But because this sort of asked, in your last 10 shifts, how many times or did you experience patient aggressive behavior in different ways, we thought that this would give a more accurate snapshot of what people were perceiving the sort of frequency of aggression on their unit. And with this, so the 5 individual items each had to be analyzed separately. And so in general, the experimental group reported less aggression at the follow-up time points in comparison to the floating group, or in comparison to the control group, sorry. And the floating group reported a decrease for 2 particular items. So I'll show you the results for just one of these, just in the interest of time. So this particular question from that scale asks, in the last 10 shifts, have you experienced physical aggression from patients? And as you can see, at baseline, the intervention and control group are not significantly different than each other, but at both follow-up time points, the intervention group is reporting experiencing significantly less physical aggression from patients. So this was the type of result that we were very excited about, because this was what we were trying to shift more than anything else. So moving into the last set of outcomes we have, it's looking at the qualitative data about facilitators and barriers to the program. And the reason that we added this is, so this wasn't originally part of our plan, was because we really struggled to get people to use the program the way that we thought that we could use. So yes, we say that we're doing better than hand washing, they're at least using one alert, but we didn't think that they would be this hard, because we really felt that this program was something that was both supporting patient care but also supporting staff. So we had the focus groups where we tried to find out from the frontline nurses as well as the managers about what things were helping them to use various parts of the program and what things were making it hard. And we want to use this to inform any changes that we have going forward. And so things that they thought were helpful is that it was integrated into their existing work routines. There were other risks that they were screening for at admission. The visual alerts were very similar to what other programs were using. They did think that both the training and all the reminders that they were given about using it really supported using it. They did, as we suspected, perceive that it was of benefit to them. They thought that the tool that we used was very simple, as well as the documentation tool for it. Interestingly, when we broke it out based on looking at, because we looked at particular what were the barriers and the facilitators for screening, for using the alerts, and for using the care plan, the only one that they reported more facilitators for was for screening, which led us to think that was probably why there was the most compliance with that. When we look at the barriers, some of the things that they noticed were barriers. So we were asking to do all this work up front very soon into when the person arrives on the unit. And at that point is when they know the least about the patient. So it's hard to develop a care plan at that point. They also wondered about resource limitations for implementing parts of the care plan. So some of the care plans, we do talk about using 2 staff to do particular types of care, and they identified that especially at night shifts when there's very few staff, it can be hard to always provide care to a patient in pairs. Again, they noticed that there was a lot of competing alerts and signage, which, because we're alerting people about a lot of risks in the hospital, we totally appreciate. They worried about the patient and family perception. Of note, we didn't have any sort of complaints from patients or families that ever arose to our attention. We had developed like a brochure and a script for staff to use with patient and families, and then we asked them to, if like the patient and family still has concerns, you can bring it to us, you can bring it to the manager, and nothing ever rose to that level. Again, just the sort of general things like that they feel stretched for time make it a barrier, that there's a lot of steps in the process, and that they felt that the care plan that we had, which was like too generic and too long, they were contrasting that with that. So Mavis and I, for patients that we're involved with, we developed very personalized care plans, and they expressed liking those care plans better, which is nice feedback, but it's also what's realistic to sort of generate when you need to generate a lot of care plans. So things that they proposed should be modified was like increasing collaboration with other units. Some of that was around like knowing that certain information is gathered in the emergency room and how do we make sure that that is passed along. Wanting things to be as automated as possible, like having things go across visits, having ways that the care plans could be printed. These are all limitations of our electronic health record. As well, having opportunities for reassessment. So some people who come in and might be delirious, which then clears, then they're no longer aggressive, but they still have these sort of labels applied to them to alert people to the possibility. So they thought that being able to like remove flags might be helpful. As well, wanting things to be on the unit whiteboard, wanting things to be like pushed in a different way of notification, asking, again, as I mentioned, for myself and Mavis to be the ones developing any care plans, and people just wanting more support in the care plans in the form of training or in the support of like other people contributing to it. There was a recent publication that looked at the way that they did flagging at Humber River. So Humber River, being a digital hospital, has these display boards right outside the room that's updated from the electronic health record. And one of the things that displays on that is if somebody is at high risk for aggressive behavior. So directly before somebody is entering the room, they can see those alerts amongst others. And so they had a qualitative study where they looked at what was the nurses' experience of using this. And the nurses did appreciate being forewarned. It helped them to feel more safe, just having that sort of being able to prepare yourself to expect aggressive behavior when you went in, and that allowed them to take preventive measures. And that there were other strategies. So the strategies they were using might be how they communicate with the patient, how they position themselves in the room. But they did talk about how even being forewarned, it doesn't mean that all aggressive behavior or violence is going to be prevented. So when we think about spreading this and sustaining this, we do think that it's important to do this. There's lots of media attention about workplace violence. It's definitely like an important issue to address. And we did see positive results from our study in terms of both confidence, but also the experience of aggression. When we look at what we were best able to implement, it was definitely the screening, but we still need to figure out how to better get people to apply alerts and how to like do the care plans. With the care plans, we didn't do any auditing of them just because it had more personal health information in terms of having a research assistant look at it. And then, so we're thinking of like doing a further study where we just have the research assistant inquiring about parts of the care plan to try and see if staff are actually reviewing it, so that they at least know about it. With the way that we implemented this, we were very happy that nothing rose to our attention about patient or family complaints. And so we are still thinking about how we're going to sustain and spread this.
Just kind of bringing a bit of a quality improvement lens for a moment. People have probably picked up on this from Carla's comments already. As we think about both kind of, scale and spread, fair to say whether it's about how we implement it here at Sinai, down the way, or other places, there are a number of things that kind of require modification depending on either spreading it kind of in our institution or others that I think are worth consideration both at the level of kind of implementation science, but also, in terms of kind of what it might be like for any institution as there are these kind of leading practices, and then how does any institution think about how it kind of goes ahead. So as Carla alluded to, we've got training challenges. There's the issue in general in healthcare and probably lots of places around alert and signage fatigue and the risk that yet another wristband in our hospital, there's wristbands for falls, it's purple. Part of why we couldn't have purple is because purple's already for falls. And if you can imagine, there was actually a multi-hour debate about whether we would use the color pink. And so almost any kind of institution has these kind of competing challenges around how to use the kind of more classic like alerts and guidance and flags in various systems. Any healthcare institution is at one stage or another in terms of the degree to which they've implemented an electronic medical record, and that has an implication. And in fact, just to go back for a moment, part of the universal precautions approach was actually because only healthcare providers at this point can look at the electronic medical record. And so in many ways, part of the screening was really guided by the fact that we wanted to kind of make sure anyone who's caring for our patients has some knowledge, the person delivering the food, the person who's the chaplain. And so even when you optimize the electronic medical record, it's really just optimizing it for workers who are the healthcare workers. With the guidance of the chief of our people plan, who's our chief of HR, we're trying to get away from this idea of like clinicians and staff, but thinking of everybody in our hospital as healthcare providers, because we all do something to facilitate it. But it's a real barrier if you're focusing all of your attention on screening at the level of the healthcare worker, him or herself. And I think fair to say the physical environment, which was really not part of our study specifically, but the physical environment of what it's like for people, nurses, patients, to be in this really cramped, crowded space while we're all trying to deliver care, is a big issue that really can't easily be addressed around screening, but is often something that we're trying to kind of guide our care plans around so that people can have more space, so that people can have a little more freedom. In terms of workflow, one of the things that kind of keeps coming to our attention is how do we think about how to keep people safe without adding to their work? And how do we kind of embed as much of the kind of screening around healthcare issues into kind of almost guiding up to a kind of determination around what might be their risks in other ways. We've been relatively successful in some of the things that we've done around that. But it is, it's hard to kind of keep people safe without adding questions around the kinds of things that may not be so evident for the reasons why they came in the first place. Maybe we'll skip over this for a second. I think fair to say, again, not in a kind of grand way, but one of the things that we were interested in terms of both safety and science is to think about not just adoption, but how easy or hard it is to actually do the thing that is supposed to be the thing that we're supposed to do. We've mentioned, I hope not too glibly, hand washing is hard to do. Don't anyone to be scared, but very few places are at 100%. And so we really wanted to understand, if we knew from our colleagues, and we have the luxury of also being clinicians in this work, that they wanted help around these problems, we had a burning platform in that sense. And yet still, when we added relatively kind of low time screening, it was still hard for people in a busy workplace with lots of things to do to implement it. And we wanted to learn from that. We wanted to learn from their feedback. And so that's why we decided to approach it not just by implementing it, but evaluating the implementation. And I hope that at least for us, and maybe for people who do similar work, it's a way not just to think about, kind of why we would want to kind of implement this, but what are some of the enablers and the barriers to that, so that, we can actually achieve those kind of most important outcomes, which is safety, not just being able to check, like, do we have a flagging system? Sure, right? It's similar in healthcare. You know, there's this thing called medication reconciliation. We've probably heard about making sure that the medicines I'm on at home are the same medicines I'm ordered in the hospital. It's one thing to say we've checked it. It's another thing to say you've done it properly. And so what we want to try to do is do it properly. So I hope, even though people have come to this for different reasons, that it's at least helpful in knowing a little bit about how we've tried to bridge kind of healthcare, worker safety, and patient safety, and happy to open it up for questions for people or feedback around things that we might have missed in terms of your experience. Thank you. Okay. Thanks.
We'll open it up for questions.
Sure.
Just ask, could you, Leslie or Carla, repeat the question so people on
Sure.
the
Should I hold
webinar
this?
will be
Okay.
able to hear? So, yes.
Hi, Erna. Hi, nice to see you. Okay.
Nice to see you that you're doing this. This is
We're trying.
fantastic. So a couple questions that I have. One would be, did you have the support of the psychiatrists and physicians, and were they also required to complete? So let's just say it got, passed by at registration, at triage, wherever. Then during their assessment, if they found that there was a history of violent behavior, how would this, program work with their assessment?
So the question was, did we have the support from the sort of physician side of the house, if you will? You tell me if I've paraphrased wrong. And how would it work around that? So I would say we certainly had support. I would say, fair to say the program, this particular aspect of the program was really more related to the kind of nursing level kind of assessment and admission type assessment, and really more about the kind of more granular assessment or observations that they made around kind of their care. We socialized the physicians to the program in part because, as you can imagine, there were pink signs on the door and pink wristbands, but it wasn't kind of part of the workflow of the physicians themselves. I would say there's a bunch of reasons why that might be true, but one of them at least is, as a teaching hospital, the turnover of physicians is also yet another barrier, right? So I think the goodish thing around a teaching hospital is that there's lots of learners and people who will run at 3 o'clock in the morning to try to help all of us. The less good thing is some of them turn over every month. And so one of the things we're always trying to figure out is, with any kind of quality improvement kind of rollout, is how do we roll out something that can kind of be almost like a hug from the permanent staff around the turnover that comes from lots of trainees.
I would say, too, that the nurses were meant to gather information not just about what they witnessed themselves in terms of aggressive behavior, but if anybody else was experiencing or hearing about anything else. So it wasn't meant to be done just based on what they actually saw, but also what they were able to gather from other people.
Yeah.
Yeah, so you raise your hand.
Are you sure? Okay, thank you, Peter. I have a question on the webinar. Someone has tried something similar at the organization, but the tool they were using was too sensitive. What questions are in your screening tool?
Oh, yeah, so I didn't talk about this here, but the screening tool we actually used was meant to only flag based on the legislative requirements. So as if they were having current aggression during their current visit, if they had a history of aggressive behavior during a previous visit, or if they had a history of aggressive behavior in an outside setting that we thought was likely to recur. So it wasn't at all about what their, I know there's other tools that look at their current behavior and try to predict the risk of aggression, but this was based solely on history, really.
And would it be self-reported by the patient, or was it gathered from elsewhere?
Gathered from elsewhere, mostly, yeah.
There's a question at the end, and then Peter, you go ahead.
Thank you. Just wondering, your continual rapid response team, what makes up that team? And I have another question. If a patient is readmitted, is there any way of carrying the information when they first came in at another time, and instead of having to reassess them again?
I'm happy to answer. Sure. The question was, can we tell you a bit more about our behavioral rapid response team? And if a patient was readmitted, would that information follow them? Is that right? Sure. So the behavioral rapid response is a kind of nursing-led, my colleague and our colleague who couldn't make it here today, she's probably rapidly responding to something. But it really, so the behavioral rapid response team is kind of two-ish optimizations at the same time. One is to try to provide nursing to nursing, sort of bedside to, bedside support for behavioral issues. The other is one of the other interventions that was part of our Safe Patient, Safe Staff program is we removed the requirement, according to our hospital bylaws, that a physician referral was needed in order to get psychiatric support. So one of the things we identified several years ago was this, in my view, kind of antiquated notion, respectfully towards any physicians who may be here or listening, around this notion of a most responsible physician being, kind of the gatekeeper around getting kind of care to the patient. And so once we can remove that, a nurse could call, basically kind of get that behavioral rapid response support. And the idea was based on really work done with code blue teams, where this idea was, rather than waiting till you had a code blue, if a patient was deteriorating, you could basically call with relatively broad criteria and say, we think this person might be about to become a code white in the next few hours. If we don't get help right away, can you please come assess, provide some intervention as quickly as possible? And the other was whether or not the information follows the patient. Can you remind me of that? I know we had some debates about whether that's possible. Go ahead.
So the information doesn't follow them between visits. Again, it's an electronic health record limitation. We had wanted it to, and we'd asked them to develop it that way, and they can't. So.
Thank you. It's a really impressive study to be able to do a randomized controlled trial. And as you said before, there's not a lot of good evaluations that have been done. I was wondering if you could maybe just talk us through the decision. I mean, what was the decision process at Sinai around wanting to invest in this type of evidence? Because, as you said, there's a lot of talk about workplace violence, but often when it comes to actually throwing the resources at it, maybe there's a bit more reluctance. So what was the process happening at Sinai that they actually engaged in let's try and evaluate something that's going on?
Thank you. Oh, sorry, let me, so no, it's a great question. I want to try to think about a good, so the question was kind of what might be happening at Sinai that would have kind of led people to kind of be, paraphrase, I apologize, like willing to invest in the resources, like probably time, people, to do this, as opposed to either do nothing, or as opposed to just say, let's just do it, like let's not spend the time to evaluate it. Sorry, I'm like a bit of an aggressive paraphraser. I'm not sure if I did that properly or not. So it's a great question. I think we, many years ago, we were able, I think, to highlight, and I don't know that it's something that any other people couldn't do, so I want to both be respectful and appreciative of the mentorship we've had, and also try to answer your question, because to be quite frank, it's a common question we get, and I want to answer it. I think that in psychiatry, we have a fairly active consult service that I'm proud of, where I think we have tried to kind of see patients with kind of the kinds of behaviors that lead to this kind of aggression, for lack of better words, as like our people, right? As opposed to seeing aggression as being like a thing that's somebody else's problem, or it's an occupational health and safety problem, or like I think we've tried to really see it as clinical rather than a security issue, or a kind of occupational health and safety question. And that's not to take away at all from our occupational health and safety colleagues. They've been our great collaborators in this. But I'd like to think that part of what we kind of did, which is similar to what probably all psychiatry departments need to do with people with addictions, is we can either say like that's someone else's thing, or we can say these are our people. And I think there were several really crummy patient outcomes where people were either getting overly restrained, or people, good colleagues were getting harmed. And we could see the pain in both the colleagues' experience, but also in the families who felt like really embarrassed that somehow their loved one had been responsible for something that was really quite injurious. And I think there just were probably, like many kind of burning platforms, a few situations all in a relative kind of row that led us to think about, and I think this is a little bit why it's worked a little bit more successfully for us than our colleagues at London, although I don't know a lot of the details, is that we tried to see this as something where it needed to live from psychiatry in order to try to address it at the level of the patient experience as well as the staff experience. And this is, of course, my bias, which is why I'm answering it this way. But I think that if it lives entirely in like the safety realm without also being supported collaboratively in the clinical realm, then I think you've got an us-them. victim. You've got to like, look what this patient did to my person, as opposed to what is happening to these poor patients where they're being seen as the aggressors, where they're being seen as the problem, as opposed to being seen as, you know, kind of vulnerable in their own right. And I think there was something about how we were able to kind of mobilize that in telling that kind of story that I think was really meaningful for people. And I think it's because we didn't kind of us them it. We kind of tried to join it together. And I think it actually really addressed something that I've learned from Carla and my many nursing colleagues, which is that, like, as I said, they will run into fire. They will do anything to kind of catch a patient who's falling out of a bed, and they get hurt. So I think we were also able to kind of feel their pain and hear their feedback, and be less critical of them for not somehow being able to come up with a great result. So I think that's a little bit about how we were able to do some of it. I think in terms of this sort of science and the resource of it, I think we had kind of mentors and leaders who were interested in at the level of health equity as well, and from that lens, because I think they could see what the story we were trying to tell around the intersect between the worker and the patient. I'm not sure, I'm sorry, it's a bit of a
So I have a
soft
question from
narrative.
Pam, and then
Sorry.
we have several also on the webinar. So, Pam, why don't you go ahead and then we're going to take some from the webinar.
Sure.
So Carla, you might want to take this one.
Please do.
But just before I ask the question, Leslie and Carla, this is just another example of how excellent that science is. This really is an
That's
excellent
kind.
example. Carla,
Very
here's,
kind.
here's the question. The results in terms of staff on the experimental group reporting fewer incidents of aggression compared to control in the follow-up period. This is probably not a fair question, but to what do you attribute that? Is it the
It's a very fair question.
Is it
Yeah.
the screening? Is it the flagging? But I bet you're going to say it's the care.
Okay,
Third option. I'll let you
yeah,
go.
so the question was around, like, for the experimental units who are reporting less aggressive behavior in the follow-up, what was the cause? Was it screening, flagging, care plans? So if anything, I think it has to be the care plans, because it has to be about how you deliver the care differently. However, my actual personal opinion is that it's just their perception. It's by having all of these things that they feel safer, and that so they're just in their their feeling of how their last 10 shifts went is like, oh, we're very supported to manage the patients with aggression, so it's going fine. I don't know that they're actually experiencing any less aggression.
Yeah, no, I would agree with that. I mean, we did was it the GIAP? There was a geriatric institutional assessment profile that we did pre and post another intervention when we first started our program, which was literally about, I think the question was around the sense of burden from behavioral symptoms of dementia and delirium. And we were quite surprised that concurrent with the other interventions as part of the four-pronged picture that I shared, that we went from being kind of an outlier in a not good way in terms of being kind of sub-average in terms of the experience of burden to being an outlier in the other way, at a time when we knew, because we were the clinical providers, that the actual amount of what we call BIB, burden in building, had actually gone up, that the numbers of patients with these kinds of problems had actually gone way up. And I'm a bit mixed about saying it. I fully agree with Carla. I think, of course, the culture of safety matters. We would hope that we would move the needle not just on culture, but I think it is about feeling like the overall infrastructure is one that aligns with safety, which it certainly is important. We hope it's also that the actual experience is better. Yeah.
So maybe
Sorry, I realize
I don't know if
I'm sorry, my answers are too long.
No, that's all right. We've got lots of interest.
Can I comment on that?
Oh.
Sure, and we do have a couple of people on the webinar. We want to make sure we get their questions. Go ahead, Bill.
So I don't know so much about the perception, but what we're seeing across the province is that their employers are having a similar system in place, an assessment tool, and then they're doing the care planning. Nurses become aware of the history and
Right.
can care
Yeah,
plan based
absolutely.
on the condition. So it's not just the perception that, we're doing things and we're watching or whatever. It's that there's more teams actually devoted to that particular care of the patient.
I think you're right.
And then the aggression is reduced because you know what the triggers and the behaviors are. So that's what I would see anyways from what I've seen across the province. So you might want to look into that. And I think once you delve into the care planning, which I know you said you did an audit, right? But I think once you delve into that is why you might see the perceptions change.
Yeah. No, I think you're right. I think I just meant to say that it's interesting sometimes when our lived experience is one where clinically we're getting called constantly around kind of the concerns, and yet people thankfully still feel safer. So great. Yeah. Sorry. Other questions, or I know you're running out of time.
Ron, why don't you,
Sure, thank you. So thank you for this excellent work. Can you comment on how cultural language needs factor into the program and how this was addressed?
Okay.
Do you have to repeat that question?
No.
Okay, because you can hear it. Okay, just so there's nothing explicit we did for cultural and language needs, but it would be amongst sort of like develop the triggers. So thinking of like people not understanding what care we want to provide, what's happening, and then in the interventions in the sense of using a translator. So these are things where it's just addressed if it's coming up in terms of the triggers or the care plan for the patient. So it's very patient specific. Yeah.
And our next question is, do you have a Code Silver in place?
Yes, we do have Code Silver.
Like this is just a spot check to me.
Yeah.
We have Code Silver. We have Code Silver.
We have Code Silver.
It's running, it's hiding, and what's the third thing?
Yeah, we didn't have any role in that, but we've been trained. Run, hide, fight. Fight is the third thing.
It's not funny.
It's not funny.
Yes.
Okay, and our last question was, how involved was the worker side of the Joint Health and Safety Committee in developing this program?
Okay, so I didn't highlight who was on the original working group, but it was in the beginning. So we had people that were from Ack Health. We had workers, so nurses from a couple of the units involved. We had people from the Human Rights and Health Equity. And then we actually trialed the program. In addition to whoever would help develop it, we actually trialed the program on one of the units. That's why one of the medical units couldn't be in the study, because they were the trial back in 2015. And then based on that, we did some adaptations before we actually rolled it out as the research study. So there was involvement.
Sorry, I think the question, just because I'm a health and safety specialist, Rona, is Joint Health and Safety Committee worker members versus from.
Oh, yeah, so no, there wouldn't have been those. There wouldn't have been people from the actual Joint Health and Safety Committee workers, no. Yeah.
Thank you. I think we're going to actually have to wrap it, but this has been wonderful. I hope you will come back with more of your studies and the work that you've done. Thank you so much for joining us today.
Thanks for having us.
Thank you.